Welcome to the CGNE seminar series today. To start us off, I'm going to read the land acknowledgement by our university. The Pennsylvania State University campuses are located on the original homelands of the Erie, Haudenosaunee, Lenape, Shawnee, Susquehannock, Wazazi nations. And as a land-grant institution, we acknowledge and honor the traditional caretakers of these lands and strive to understand and model their responsible stewardship. We also acknowledge the longer history of these lands and our place in that history. So good afternoon, everyone. My name is Janice Whitaker, and it's my pleasure and privilege to serve as the administrator and community liaison for the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence here at the Ross and Carol Neese College of Nursing at Penn State. This seminar is being brought to you by CGNE, as well as the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, Concepts and Considerations for the Hospitalized Geriatric Trauma Patient, will be presented by Jasmine King, acute care practitioner with the Division of Geriatric Medicine at Penn State Hershey Medical Center. I had the pleasure of meeting and spending time with Jasmine last spring at the University of Alabama's Geriatric Scholars Training. So it's a delight for me, and I'm sure it will be for you to meet and get to know Jasmine and her expertise with older adults. But before we begin the presentation, we do have some disclosures and announcements to make. So Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire Nursing Continual Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. In order to earn contact hours, we do document Zoom in and out times, and we do require that all participants, especially RNs seeking contact hours, complete the post-event evaluation survey. Just as a reminder, the seminar is being recorded. If you have questions for our speaker, you may put them in the chat, and we'll keep an eye on that. You can also raise your hand, and Amy Caputo will unmute you and invite you to make your comment or ask your question out loud. And as a reminder, Jenny will be putting the post-event evaluation link into the chat towards the end of the seminar. You can begin to complete it then, or you can do it later when it works for you. It'll also be emailed to you within 24 hours. But we do ask all RNs seeking contact hours to complete the form within a week of the seminar. And we do ask that all participants complete the evaluation to provide us with feedback about the seminar as well as our center activities. Certificates for RNs will be sent to you via email within a month of the seminar. If you have any questions at all, please feel free to reach out to us at cgne@psu.edu. And next, I'd like to introduce Aza Al-Hassari, one of our CGNE PhD student affiliates. Aza is in her first year as a PhD student, but earned her MSN at Penn State in nursing education, as well as adult gerontology. She's an acute care nurse practitioner. Aza has and will do great things, and we thank her for introducing our seminar today.
Thank you, Janice. So Jasmine King is an acute care nurse practitioner with the divisions of geriatric medicine at Penn State Health Milton Hershey Medical Center, where she has served as the anchor for the inpatient geriatric medicine consult service since February 2020. Prior to obtaining her master's degree in nursing from Drexel University and obtaining MB certification and licensure in 2019, she was a bedside medical surgical ICU nurse at a level 1 trauma center in Allentown, Pennsylvania from 2011 until January 2020. Her professional affiliations include being a member the Gerontological Advanced Practice Nurses Association, American Geriatric Society, Pennsylvania Coalition Nurse Practitioner, and the American Association of Nurse Practitioners. In her current practice, Jasmine is dedicated and interested in helping all staff members learn how to provide age-friendly care to the hospitalized older adults. So welcome, Jasmine.
Thank you, Azza, for the introduction. Let me share my screen with you guys. Okay. All right. So today I'm going to be talking to you guys about the concepts and considerations in caring for the hospitalized geriatric trauma patient. And I do not have any personal disclaimers or disclosures. As far as objectives, we are going to be identifying the most common traumatic injuries incurred by the older adult patient, review the physiologic changes associated with aging and how it affects the way traumatic injuries present in older adults, explain why older adults are at increased risk for complications in the hospital, explain how a collaborative multidisciplinary approach to the care of geriatric trauma patients can improve outcomes, and discuss the management considerations for the care of the hospitalized older adult using the 5 M's approach. So since you'll be hearing the term geriatric trauma throughout the presentation, I just want to clarify and explain exactly what a geriatric trauma is. And a trauma is defined as any serious physical injury to the body, and there are 2 main types of physical trauma. You have your blunt trauma, also known as non-penetrating or blunt force trauma, which is caused by forceful impact, falls, or physical attacks with a dull object. Blunt trauma injuries are classified into 4 categories, including contusions, abrasions, lacerations, and fractures. And then you have penetrating trauma, which is the second main type of trauma, which is when an object pierces the body, causing a wound, such as a gunshot wound or a stab injury. And then secondly, what exactly defines a geriatric patient? And there's a lot of debate regarding exactly at what age a patient should be considered an older adult patient. There are some studies that suggest starting as low as 50 years old, but most studies use 65 as the threshold to define the geriatric patient. There are observational studies that have shown us that we can't just look at chronologic age. A lot of times when looking at a patient's age, we also have to look at their physiologic or biological age. So we know that frailer older adults are more susceptible to complications compared to healthier older adults. And that's something we have to look at when we're looking at an age of a patient. So in almost every developed country, we know that the proportion of people 65 and older is growing and compared to every other age group. And this is typically due to longer life expectancy and declining birth rates. According to the US Census Bureau, the number of individuals 65 and older, which was only around 35 million in 2006, increased to 54 million in 2019, is going to jump to 70 million by the year 2030 and more than 86 million by the year 2050, which means 1 in 5 people will be considered an older adult. And consequently, older adults will make up more than 21% of the overall US population, with almost 39% of trauma admissions being older adults by the year 2050. From a financial perspective, geriatric traumas account for $12 billion annually in medical expenditures and about $25 billion in total annual healthcare expenditures. So this graphic here breaks down the most common mechanisms of traumatic injury for older adults, from most common to less common. Not surprisingly, falls and motor vehicle collisions are the most common mechanisms of injury among older people. And we'll talk a little bit more about falls and motor vehicle collisions in the next couple of slides. And while penetrating traumas like our gunshot wounds and stabbings are not as common in older adults, they are definitely associated with higher morbidity and longer hospital stays compared to younger patients. We don't typically see burn injuries just because Hershey's not a burn center, but we do know that they have a devastating effect on older adult patients in whom mortality is significantly higher for any size or kind of burn compared to younger people. And as far as assaults and abuse, unfortunately, we do see this from time to time. So it is very important as providers to always consider the possibility of an older adult being abused, as well as an older adult having suicidal ideation or attempts when caring for older adult trauma victims. So falls is a public health concern among the aging population, just because of the fact that 1 in 4 older adults will fall each year, and about 3 million older adults will be treated in the emergency department for fall-related injuries. Most falls are not mechanical in nature. And when you hear the term mechanical fall, this refers to a fall that is caused solely from an external factor or an environmental factor. And we know that most falls are actually because of a combination of risk factors. And the more risk factors a person has, the greater their chances of falling. We look at things like lower body weakness, vitamin D deficiency, difficulties with walking and balance, vision problems, poor footwear, and use of medications that can affect the brain, such as tranquilizers, sedatives, and antidepressants. We know that these factors increase a patient's fall risk, and unfortunately, older adults tend to have more of these risk factors for falls. So it's important not only in the inpatient setting, but also in the outpatient setting to assess our patients for these risk factors, do thorough falls inventory, and make sure that we are trying to prevent falls as much as we can in our older adults. And as far as motor vehicle crashes, this is the second most common mechanism of injury in our older adults, but it is associated with the highest mortality rate in the geriatric trauma population. In 2020, about 7,500 older adults were killed in traffic accidents, and almost 200,000 were treated in the ED for crash-related injuries. When it comes to older adult drivers, we know that there are age-related changes that may increase the risk of accidents, including vision and hearing impairments, impaired physical function, slowed reaction time, cognitive impairment, and as well as chronic diseases and some medications that may affect one's ability to drive safely. And because of this, this is another thing as far as us as healthcare providers having to routinely assess for in both the inpatient, outpatient, and community setting, as far as whether our patients are exhibiting any of these age-related changes that may affect their ability to continue driving safely. So next, we're gonna talk about some of the anatomic and physiologic changes that accompany the aging process and place the geriatric trauma patient at a greater risk of injury and death. And we know that these changes also impair the older adult's ability to respond to the stress of a severe injury. And as you can see from the chart there, I kind of have it broken down by organ system as far as what physiologic changes you'll see and what implications it'll have when we're caring for older adults. And for sake of time, I won't go through every single organ system, but from a cardiovascular standpoint, we know that as we age, our heart muscle gets stiffer, which does compromise our cardiac output. And as we get older, we also are less sensitive to the release of catecholamines, which is a hormone released in a trauma or any type of stressful event. So when this happens, older adults don't exhibit the same response to shock, trauma, hemorrhage, and pain like a younger person would. Older adults have a less robust tachycardic response. So when we're looking at things like shock, we may not see that elevated heart rate right away. So as clinicians, we tend to have a lower threshold of concern when we are monitoring and trending in older adults' vital signs, just because they are at higher risk for hemodynamic instability and may not show the normal physiologic changes that we expect to see in the event of a shock or a trauma or a stressful event. Some of the other considerations are that as we age, our drug metabolism is altered. And this is due to multiple things, including increased total body fat, reduction in lean body mass, as well as declines in our hepatic and renal function. So this not only complicates the inpatient side of things when we're trying to manage patients who have these traumas and may have certain responses to medications we're giving. But on the outpatient side of things, we know that with these changes in drug metabolism, we have patients that are on multiple medications that may increase their risk of falls that bring them into the hospital. And there have been meta-analyses. There was one in 2019 that did report a very strong association with the use of medications like benzodiazepines, sedative hypnotics, and antidepressants, and falls in older adults. So then we're now going to go through some common injuries that we see in older adult traumas. And we're going to first talk a little bit about head injuries, which are usually sustained by blunt force trauma to the head or brain. And typically this is because of a fall. Possible injuries that you may see are things like facial lacerations, contusions and abrasions, skull fractures, concussions, or intracranial bleeds. And there are many different kinds of intracranial bleeds, but the most common one that we see in older adults is called a subdural hematoma or a subdural hemorrhage. And these bleeds are actually 3 times more common than in younger people. And there's a physiologic reason for that. What happens is that the dura, which is the outermost layer on the brain, it adheres tightly to our skull, and there's small bridging veins between the dura and the skull. And these veins, as we get older, become stretched and easily break, and increases the risk of subdural hemorrhage from very low impact injury. The other thing that happens is as we age, we lose approximately about 30% of our brain size between the ages of 30 and 70. So this brain atrophy increases the space in which blood can accumulate, which delays the development of the symptoms and signs we look for when a patient has a head injury or a head bleed. So because of this, when patients or older adult patients come in to the hospital with any kind of head injury or head bleed, typically they are admitted to the ICU and a higher level of care. So we can keep a really close eye on their neurologic status because they can become very unstable very quickly. Other considerations are that older adults are more likely to have comorbidities that require the use of antiplatelets and anticoagulant medications, which obviously makes them more prone to intracranial bleeds in the setting of head trauma. So if you do work in the inpatient setting, if you work in the ED, or even if you work in like the pre-hospital setting, it's really important to know if you have a patient that comes in after a fall, especially with head trauma, what medications they take, if they're on anticoagulations, when they last took them, and whether or not we should be looking at any reversal agents to help stop or slow any major bleeding. Older adults can sustain very serious injuries to the spine from very low minor mechanisms of injury, meaning just from like a fall from standing, they can sustain pretty severe spinal fractures. And things that we look at that increase in older adults' risk of spinal injury include things like cervical stenosis, degenerative rheumatoid and osteoarthritis, which are typically more common in older adults. There are certain types of spinal injuries that appear to be more common in older adults. So one of the most common is called an odontoid or a dens fracture. And this is a fracture that occurs on the C2 vertebrae. It's the most common fracture of the axial skeleton and the most common type of a cervical spine fracture in patients 65 and older. And see if I can do this. If you can see on the picture at the top here, this bony prominence, this is called the dens or the odontoid. And what happens is that as we age, there are relatively larger reductions in the bone density at the base of the dens or the odontoid relative to the remainder of the C2 body. And that structural weakness of the odontoid base coupled with the increased bone loss due to aging causes a higher rate of fracture of that specific area in our older adults. A lot of times, spinal injuries are managed non-operatively if the fractures are stable and non-displaced, and that is determined by either the orthopedic spine team or the neurosurgery team, just depending on whether or not there is involvement with the spinal cord or risk of spinal cord impairment. And as far as what non-operative management looks like, with our cervical injuries, patients typically end up in what you'll see at that bottom picture there, which is a hard cervical collar. This is a collar that's used to support the neck bones and the ligaments, and it reduces any movement that may cause further damage to the cervical spine and neck injury sustained. And then this picture here on the right, this is called a TLSO brace or a thoracic lumbar sacral orthotic brace. This is used to limit the motion in the thoracic lumbar sacral region, depending on where the injury is. Sometimes this is used post-operatively as well, just to help keep the spine in a neutral position. There are, unfortunately, even though these are non-operative choices, they come with a set of complications as well. Things that we worry about, especially with the hard cervical collar, are things like dysphagia. Our older adults are more susceptible to swallowing impairment, and with the neck braces, unfortunately, it puts their neck in a hyperextended state, which can increase the risk of aspiration. And then as far as the TLSO brace, excuse me, we worry about pressure sores and injuries. These braces don't always fit the nicest, and they can cause some skin breakdown. So that's another big concern that we do have to worry about. And unfortunately, with non-operative management, especially with the cervical injuries, these patients can end up in these braces for several weeks to months. If the break is severe enough and the patients aren't a surgical candidate, they can end up in these collars for life, depending if they're really advanced in age. So it's, you can really imagine the discomfort and the impact on quality of life this can have on an older adult patient if they have to wear these kind of braces. When it comes to thoracic injuries, older adults, they do have a reduced vital capacity and chest wall compliance as they age. And this causes diminished respiratory reserve, limiting the ability to tolerate even minor trauma to the lungs or the chest. The other thing that happens is that as we age, our responses to hypoxia, hypercarbia, and acidosis are often blunted. So sometimes clinical assessment can be really challenging. As far as injuries to the thorax, the most common thing that we see are the rib fractures, and they are associated with complications like atelectasis, pneumonia, hemothorax, which is blood collection in the lung, and then pneumothorax, which is a collapsed lung. And due to the serious risk factors associated with rib fractures in older adults, it's not uncommon for some hospitals to have a protocol in place to prevent these complications from arising. At Hershey, we do have a geriatric rib fracture protocol for anyone who's 55 and older who has 2 or more rib fractures on the same side. They are typically admitted under the trauma surgery team to either the ICU or the floor, just depending on their clinical status. And this protocol focuses a lot on preventing trying to prevent the complications I talked about previously, by instituting measures such as early mobility, pain control, and pulmonary toileting, and assuring that respiratory therapy is following these patients really closely. As far as musculoskeletal injuries, these are the most common types of injury we see in older adult patients. And partly this is because of the lower bone density and compliance that's associated with aging. Hip fractures are by far the most common injury that require hospitalization after a fall or a trauma. And at least, or each year, there's at least 300,000 older people that are hospitalized for hip fractures. More than 95% of hip fractures are caused by falls. Other fractures that we tend to see in the musculoskeletal system include fractures of the pelvis, fractures of the distal, radial, and ulnar bones, which are the wrist, and then the proximal humerus, which is the upper arm. Pelvic fractures are typically managed non-operatively, depending on their stability and whether or not they are displaced. And then fractures of the arms and legs are more often managed with surgery. However, many times, especially the upper extremity fractures, they may be treated non-surgically with splinting if the bones are not severely displaced. And you can see a picture on the right side. That's a Sarmiento brace. It's a kind of an arm brace that's used for humeral fractures. And then obviously the other picture in the left there is a type of fixation for a hip fracture. So we're going to pivot a little bit and we're going to talk about geriatric syndromes. And this is a term that is often used to refer to a common health condition in an older adult that may not fit into a specific organ-based disease category and often has multiple causes. These conditions are common in older adults and may have a major impact on their quality of life and disability. These include things like cognitive changes, falls and gait disorders, malnutrition, sensory impairment, sleep disorders, and incontinence. And unfortunately, many geriatric syndromes contribute to the development of a major syndrome known as frailty, which you see in the middle there. And frailty is an age-associated decline and physiologic reserve and function across multi-organ systems, which can lead to increased vulnerability to stressors, which often leads to adverse health outcomes. So special considerations should be taken for the care of older adults in the hospital, especially those with advanced age or those who have or are at risk for geriatric syndromes. So while the hospital has been seen as the traditional model for the delivery of acute medical care, we know that it is often not an ideal care environment for many patients. Many older adults are susceptible to other complications not directly related to what brought them into the hospital in the first place. And older adults are at greater risk for what we call hazards of hospitalization. And this includes iatrogenic events, such as nosocomial infections, pressure sores, delirium, functional decline, medication side effects, use of restraints, and falls, which can all lead to complicated transitions in care and prolonged hospital stays. So while hospitalization in this population is often necessary, it is important for us to acknowledge that there are major risks associated with caring for older adults in the hospital. In order to try to reduce the risk of older adults sustaining hospital-acquired complications or hazards, many healthcare systems are trying to implement an age-friendly approach to the care of the elderly in the hospital setting. Age-Friendly Health Systems is an initiative of the John A. Hartford Foundation and the Institute for Healthcare Improvement that aims to address an older adult's unique needs and the goal of promoting what they determine to be a good quality of life. This is an evidence-based initiative that's aimed to cause no harm and center around some of the most important things to pay attention to as our patients age by using what we call the 4 or 5 M's approach based on what source you look at. So we use the 5 M's framework here at Hershey with our service. So that's what I'm going to be referring to now. And the 5 M's framework helps guide the care team in providing effective age-friendly care. So when we look at mind, we are trying to maintain an older adult's mental activity, helping manage dementia, helping to treat and prevent delirium, and working to evaluate and treat depression. With mobility, we are helping maintain the ability to walk and maintain their balance and preventing falls and other types of common injuries. With medications, we are trying to address polypharmacy. We are making sure we're prescribing treatments that are exactly for an older person's needs. And we are helping to build awareness around the harmful effects of certain medications. And then I'm sure a lot of you are familiar with the 4 M's, but in 2017, Canadian and US specialists in geriatric medicine officially launched the 5th M, which is multi-complexity. And that is helping older adults manage a variety of health conditions and assessing living conditions that may be impacted by age, health conditions, and social concerns. And then the last M is matters most, arguably probably the most important, which is making sure that a person's individual, personally meaningful health outcomes, goals, and care preferences are reflected in their treatment plans. And we also help to coordinate advanced care planning. Geriatrics is known for its team-based approach to caring for older people and working with families and other caregivers. And the multidisciplinary care team may include, but isn't limited to, any or all of the following roles that you see in that graphic on the right side there. And guided by the 5 M's, our inpatient consult service proactively helps our patients. We see all of our trauma patients that are 70 and older, and we proactively perform comprehensive geriatric assessments, assessing and addressing any concerns for geriatric syndromes. Some of the most common geriatric problems that we typically address are things like delirium prevention and management, treating or helping to treat patients that have dementia with behavioral disturbances, addressing polypharmacy, addressing goals of care, performing cognitive and capacity evaluations, and addressing any concerns with falls and feeding difficulties. We may also help determine safe and feasible discharge plans and help to recommend appropriate referrals and resources for outpatient geriatrics clinical programs. So now we're going to apply the M's to a fictional patient case. In the next few slides, we have scenarios pertaining to each M, and on the right side of the slide are questions and considerations that pertain to the specific geriatric problem being described on the left side of the slide. So here we have Mrs. Smith. She is an 81-year-old female. She is a widowed retired chef who lives in an independent living apartment in a senior living community with her dog. She is independent with all of her ADLs and IEDLs except for driving and shopping. And she has a past medical history for chronic lower back pain on chronic oxycodone 5 milligrams TID, macular degeneration with legal blindness. She's had an old stroke with chronic right lower extremity weakness. She has osteoporosis and osteoarthritis of the left knee. She was brought to the hospital after a ground level fall, which is essentially a fall from standing, while walking her dog outside. And she does admit she went outside with slippers on and thinks the fall was completely due to tripping on an uneven portion of the sidewalk. However, upon further inquiry, she admits she's had 2 other falls within the last month, one in her home when getting up from bed to use the bathroom, and one in the shower. So in the emergency department, she was found to have a right hip fracture and a right proximal humerus fracture. She was admitted to the trauma surgery team with orthopedics consulted. Her humerus fracture is being managed non-operatively in a sling, and she underwent a right hip hemiarthroplasty with orthopedics and is now post-op day 1, currently on bed rest and pending physical and occupational therapy consults. So when we are looking at mobility in an older adult trauma patient in this situation, first off, we ask ourselves, why do we think this patient fell? Was this truly a mechanical fall, or were there other factors at play that could have caused this fall or her previous falls? And in Mrs. Smith's case, she may have tripped over the sidewalk, but she definitely has other multiple factors and conditions that could have contributed to this fall or her previous ones. She's had an old stroke with right leg weakness and right foot drop. She has left knee arthritis. She has vision impairment due to macular degeneration, and she chronically uses opioid analgesias for back pain. So this can all increase her risk of falls. As far as recommendations to optimize her mobility and reduce risk of future falls, obviously physical and occupational therapy plays a vital role in this, as they're able to provide a comprehensive evaluation and provide the patient with exercises to help with impaired gait, balance, and transfer skills. And they're able to evaluate whether she would benefit from an assistive device for mobilization. And they're also able to comment on what the most appropriate discharge plan is for her when it comes to therapy services. When we're looking at things to help reduce risk of future falls, we try to address any modifiable risk factors. So looking at things like with her right leg weakness, does she use any type of orthotic brace? With her vision impairment, has she followed with an ophthalmologist? And is there any treatment or management for her vision impairment? And then we also look at things like making sure a vitamin D level's been checked and ensuring she's had some kind of workup and treatment for her osteoporosis in the past. We try to encourage as much mobility as we can while she's in the hospital, encouraging she get out of bed for meals, encouraging as much independence with her ADLs as possible, and continuing to encourage range of motion and resistance exercises while she's in bed. And as far as other considerations that we anticipate regarding disposition planning, anyone who works in the hospital setting knows that we try, or we should try to start discharge planning on hospital day one. So continuing to encourage discussions among the patient, family, and the care coordination or social work team regarding the goals for discharge, as well as what the possible discharge scenarios may look like for this patient. So post-op day one, Mrs. Smith was seen. She was noted to be in a severe amount of pain, limiting her ability to participate with therapy. She didn't sleep overnight due to the pain and rated it a 9 out of 10 using the numeric pain scale on assessment this morning. She appears visibly uncomfortable, restless, and frequently grimacing. And when we look at her current pain regimen, we see that she is on Tylenol 1 gram TID, as needed oxycodone 2.5 to 5 milligrams every 4 hours, and a transdermal lidocaine patch to the right hip every 24 hours. So we were asked to see Mrs. Smith and comment on what we think is going on and what we can do to help her. I bring up this scenario because unfortunately, sometimes in our older adults, what we see is that they may not be adequately treated for their pain. Obviously, with older adults, we do worry about opioid analgesia affecting a patient's cognition, but we also have to worry about under-medicating our patients, because uncontrolled pain can increase the risk of delirium and lead to other complications, like patients not being able to tolerate therapy and losing a lot of their functional ability and having a newly acquired functional decline because of the inability to work with therapy. So in this situation, what's most important is ensuring that we're treating Mrs. Brown's acute on chronic pain. The fact that she's already on oxycodone 3 times a day at home indicates that she definitely needs her regimen increased. And some of the other considerations that we can look at are that, at least here at Hershey, we have an acute pain management service who's able to comment on the pain medication regimen, but what can also happen is that sometimes patients can have a peripheral nerve block catheter placed. Particularly, we like to use them for hip fractures and rib fractures, but these nerve block catheters, they're able to deliver localized anesthesia, or it's usually lidocaine or ropivacaine to the area of injury, which tends to minimize our use of the opioids. So if patients are eligible for that, that's something we definitely try to advocate for. And once again, pain management is super important, just because we're trying to minimize our patients' risk of complications such as delirium and functional impairment. So now we are moving on to a mind scenario. We see Mrs. Smith on post-op day 2 for a follow-up visit. She's noted to be acutely confused, restless, and having visual hallucinations. She got 2 milligrams of IV haloperidol overnight. And when we see her, she's in bilateral soft wrist restraints because she's trying to remove her indwelling urinary catheter. So when we see the scenario, we immediately ask ourselves, what is happening to Mrs. Smith? Why do we think this is happening? And how do we help Mrs. Smith now? What is happening is known as delirium, which is an acute change in a patient's baseline mentation with a fluctuating course, and this is associated with inattention, disorganized thinking, and altered level of consciousness. And this happens for a variety of reasons. So as far as why it's happening, we have to look at each patient specifically and determine what their predisposing factors were for becoming delirious and what factors precipitated the delirium. So with this particular scenario, we know Mrs. Smith, she has had a history of a stroke, which may affect her baseline cognition. She also has a history of legal blindness and is visually impaired. So with that sensory deficit, that is a predisposing factor for delirium. As far as precipitating factors, she's had many factors that are likely contributing. So she was under medicated for pain. She's a post-op orthopedic patient, and we tend to see delirium a little more in the post-op orthopedic patients for some reason. She has a urinary catheter. She is restrained. She didn't sleep the night before because she was in pain. So these are all things that could be contributing to the delirium. And as far as how we help her, the first line for delirium management is always non-pharmacological. So educating the providers and the staff that we need to implement things such as a normal sleep-wake cycle, reorient the patient as much as we can, promote family presence at the bedside, continue to mobilize the patient as much as we can, and then on our part, assessing for any reversible etiologies for the delirium. So things like making sure she's not constipated, she doesn't have urinary retention, making sure her pain's controlled, and then obviously treating any metabolic or electrolyte disturbances that can sometimes trigger and precipitate delirium as well. The biggest thing with delirium is, at least I feel, is that we need to provide anticipatory guidance and education to the families, because it's very stressful to see their loved one in the bed in a completely altered state and not really understanding what's going on. So just explaining to family what's going on and providing them that guidance, it definitely goes a long way. So as far as matters most scenario, now we're on post-op day 4. Mrs. Smith's delirium is slowly resolving. She's following with PTOT, who are now recommending inpatient therapy at discharge. However, today she was noted to be coughing with her breakfast, and after a speech language pathology evaluation, found to have some mild to moderate dysphagia, and her diet was changed to a pureed diet with honey thickened liquids. So when we see her in the afternoon, Mrs. Smith is crying and she's refusing to eat her lunch. So in this situation, we ask ourselves, what can we do to assure that we're honoring Mrs. Smith's values and priorities when it comes to her care and her quality of life? And this is done obviously by having an open, transparent discussion with the patient and the family about what their long-term goals are when it comes to Mrs. Smith's care moving forward and what matters most to her. I don't know if you remember, but in a few slides back, when I initially presented the scenario, she's a retired chef. So theoretically, or after speaking with Mrs. Smith, we realized that eating and drinking matters a lot to her, and she really doesn't want to be on a thick and liquid diet. So after we take the time to address what dysphagia is and give and explain the recommendations that were given by the speech language pathology team, we then offer the options to the patient depending on what her goals are and what her priorities are, and assuring that we go over the risks and benefits associated with each option. So as far as outcomes for Mrs. Smith, after we have a shared medical decision-making discussion with her, she decides that she wants to be placed on a soft diet and wants to drink thin liquids. And we also review and discuss resuscitative measures with her and complete a pulse, which will go with her to rehab. Mrs. Smith was discharged to rehab on hospital day 6 with PTOT and speech language pathology services. She was at rehab for 21 days before going back to her home living situation, but unfortunately transitioned from independent to assisted living due to the need for increased needs with her ADLs. Her delirium has resolved, however, she still complains of a little bit of brain fog, which she is planning to follow up with her PCP for. And she continues to receive PTOT services at her assisted living 3 times a day. So although this was a fictional scenario, it's one we regularly see in the inpatient setting. And with all real life scenarios, it's important to continue addressing the older adults' care needs using the 5 M's framework across the care continuum. So just some takeaways from our talk. Once again, as our population continues to age, we're going to expect to see more older adults coming into the hospital with traumatic injuries. These injuries are typically due to falls and motor vehicle collisions. And the most common injuries that we will see are fractures of the spine, especially the cervical spine, ribs, hip, and extremities. And as we know, the anatomic and physiologic changes associated with aging are going to place our older adults at greater risk for injury and death from physical trauma. Age-friendly care aims to use evidence-based interventions to prevent and treat geriatric syndromes, which can lead to hazards of hospitalization. And when it comes to managing traumatic injuries, many of the interventions we do may not be compatible with what an older adult would deem to be an acceptable quality of life. So it's important for us to address the geriatric trauma patient's wishes and priorities when it comes to the plan of care. And once again, the implementation of the 5 M's requires the efforts of the entire multidisciplinary team across all care settings. We all play a role in age-friendly care. So thank you guys once again for having me. I know we're gonna have a Q&A after, but if there are questions, comments, or concerns that come up later on, please feel free to email me. And then these are just my references here. All right. Thank you, guys.
Well, thank you so much, Jasmine, for an outstanding presentation. Oh my goodness, it was so comprehensive in terms of sharing the multifaceted ways that older adults present themselves to an acute care setting in relationship to traumas they may experience, as well as some of the unique characteristics of older adults that providers may need to take into consideration. And one quote that I'm thinking about a lot as you presented was that providers may have a lower threshold of concern related to some of the physiological changes that occur with older adults. And so, certainly having you and others at the Division of Geriatrics in on consultations and sharing your expertise is incredibly valuable. And I also appreciate the fact that you shared the 5 M's and shared that case study with us in the context of that. Very helpful information, and appreciate the fact that you and your colleagues are using that framework to improve care for older adults in the clinical setting. So we're going to take a quick pause here. I see that Jenny did put the link to the evaluation tool in the chat. So if people want to, copy and paste that and go ahead and get started on the evaluation. You may choose to do that. I'm going to pause very briefly and we'll resume with some Q&A and discussion. We've already got some comments coming in. So we'll pause for just a minute. So that probably wasn't even a full minute, but you know, Jasmine, there are some great comments coming in and some good questions. So if people are still working on the evaluation, please continue to do so. But I'll go ahead and get started with, we're hearing lots of people mentioning excellent presentation, very pertinent. Thank you so much for all the information. In the Q&A, Jan Menino mentions that she's a retired nurse anesthetist, and she comments that it was a very good presentation. She wants to make a couple points. Anesthesia in the elderly trauma patient is obviously different than in the younger patient. It's especially noteworthy that if they have a pre-existing cognitive issue, it may become worse with general anesthesia. And the second point is that many CRNAs are practicing opioid-free anesthesia, which may include a long-acting block in the operative area, thus reducing the need for post-op pain meds. And she thanks you for this education. Do you want to comment on that at all, Jasmine?
Sure. Thanks, Jan, for the comments. I'll definitely agree as far as anesthesia. Definitely having effects on our older adults that may already have pre-existing cognitive issues. We've seen it, unfortunately, where patients come in for even like scheduled procedures and have anesthesia, wind up getting delirious on top of underlying cognitive impairment, and sometimes never get back to where they were before the procedure. So unfortunately, I think there's some room for education when it comes to letting patients know, especially older adults that may have cognitive impairment, when they come in for procedures, that there is a risk, there's definitely risk associated with it. So yeah. Thank you.
Excellent point, excellent point. And Marie Boltz comments that fabulous presentation that demonstrates the strong science and art of gero nursing. I think we all would concur with that. She's asking, you know, for our students, what drew you to this specialty nursing practice?
Yeah, so to be honest, I didn't even know a position like this existed when I got out of NP school. I just thought I would see myself in like a hospitalist type position, but when I saw the opening for this and saw the opportunity to take care of older patients that are very complex, I definitely jumped at that. Working in the ICU, unfortunately, I took care of a lot of older adults that had a lot of interventions and a lot of things done to them that maybe necessarily weren't things that should have been done, but we do them because, you know, that's what we do. We try to prolong life or save lives. So just being able to advocate more for older adults, it definitely has been empowering for me. So I think that's what drew me most to it.
Yeah, well, thank you for sharing that. Donna Fick also comments, excellent presentation. She's curious about what tool you're using to screen for delirium and monitor delirium severity. And then she has a couple of other questions related to Haldol and non-drug approaches. So let's start with the delirium screening piece.
So right now we are working on trying to institute a hospital-wide delirium screening tool, because right now Hershey doesn't necessarily have one. The ICU uses the CAM ICU, but as far as the floors right now, there isn't one. We did a really small pilot with the 6th floor acute care nurses, and we've been using the UB2 screen for that, which Dr. Fick, I know you're spearheading. So that is a tool that we are instituting or trying to institute, and hopefully able to start piloting on the other units.
Great, thank you. She asks if your Haldol is Haldol your protocol for delirium, and if so, what evidence is this based on?
So Haldol is typically the go-to if we have to use pharmacologic pharmacologics for agitated delirium. As far as other things, sometimes providers will order quetiapine or risperidone. And unfortunately, as we know, there isn't really any FDA-approved medication for delirium management. So it's more so just, I don't know if just the culture of, this hospital, that's kind of what we have done and used.
Yeah, and several comments in the chat related to the fact that it's awesome that you have such a strong ICU background as well. That's got to be, really instrumental in terms of not only the care you provide, but your relationship with other practitioners and how you can assist with consultations and things like that.
Definitely.
Yeah. So how do you talked about, the first line of delirium management being non-pharm approaches. And I'm sure you're implementing non-drug approaches in other areas of geriatric care. How do you assist the staff with that? How do you work with staff around non-pharm?
A lot of it is just direct, education with the nurses and the staff. When we do see these patients, just taking a little bit of time to talk with the nurses about the experience they're having and what they have been able to do from a non-pharmacologic standpoint when they're taking care of patients that are delirious. We would love to be able to do almost like a small like Jerry rounds with the floor, and delirious patients that they have on their floor, being able to kind of round on those patients and kind of talk to the nurses all at the same time, as far as interventions and things they could be doing. But a lot of it right now is just like one-on-one, discussion with them when we see the patients.
Or maybe even trying to do some huddles from time to time.
Yeah, that was the word I was looking
can't do
for.
the rounds, but yeah. I also loved what you were talking about in terms of anticipatory guidance with families, because doing that type of education is really important and helping them understand what's going on and how they can be helpful as well.
Mhm.
Yeah. So Diane is also commenting, what a great presentation. She's asking, do you have any suggestions for ways that healthcare professionals can work to advocate that after an assessment is done for something like dementia or falls risk, how they can follow through happens to help improve ultimate outcomes? Does that make, okay.
Yeah, ideally, we would love to be able to have more of a connection with the outpatient side of things. So when we are picking up on these things in the inpatient setting, as far as concerns for dementia or recurrent falls, they're able to follow up with a geriatrician after their hospital stay. Unfortunately, we're very limited because we don't have many geriatricians available in the outpatient setting. But when we are able to, we try to, at least with our service, we have cards that we give to family members with our information for our outpatient providers, hoping they'll follow up with us. The other thing that we try to do is we do warm handoffs to the primary care provider sometimes. If we have really significant concerns about what we see here in the hospital, sometimes we'll call the primary doctors directly and let them know what our concerns are, just so it doesn't fall through the cracks. So just taking that extra step to reach out to that.
Yeah, that's a critical, important extra step. So thank you to you and your colleagues for doing that. That will, hopefully make a huge difference. I'm afraid we're at our 1 o'clock time, our end time, but lots of really positive feedback about the presentation, about your expertise, about how you and your colleagues at Hershey are doing an outstanding job moving age-friendly care forward. So thank you so much, Jasmine, for being with us today, and to everyone for joining us. Have a great rest of your day.
Thank you so much.
Thank you.